Dear colleagues, good evening. First of all, I would like to thank Professor Vasilis for this nice invitation. The topic of this discussion is about 24-hour ambulatory blood pressure and stiffness, a new early vascular aging index from ABPM. There is no conflict of interest for this presentation. First of all, we will start from pulse wave velocity in order to identify the early vascular aging. As you can see here, normal carotid femoral pulse wave velocity values were reported for the first time in 2010. Data were collected from 13 different countries in 8 European centers, in 8 European countries. And they were collected from healthy participants without other health problems and with normal blood pressure values. The normal carotid femoral pulse wave velocity values were estimated to be around 6 for those being under 30 and around 10 for the healthy population at the age of 70 years old. You can see here the distribution of arterial stiffness in healthy population with normal values. For those being less than 30 years old, the values were lower, but as the age getting increased, the number are getting increased too for pulse wave velocity. Here you can see how to define early vascular aging from carotid femoral pulse wave velocity. And you can see on the slide that if you have a specific healthy individual for a specific time of his age, a number of damaged arterial wall. When this damage is higher for his age, then we say that this population has early vascular aging. So early vascular aging is the acceleration of vascular aging. And here is how to define early vascular aging from carotid femoral pulse wave velocity. As you can see here is the Z-score of pulse wave velocity, and this is the measured pulse wave velocity minus the normal for age pulse wave velocity divided into standard deviation. And when we have the Z-score higher than the 95th percentile, then we say that, okay, our patient has early vascular aging. And why it is so important to look for early vascular aging in our patients? It is important, first of all, because it is a non-invasively easy way to calculate for cardiovascular risk. Also, it is an arterial tissue biomarker that may be more predictive than circulating biomarkers like high sensitivity CRP. It has also better additional prediction when coupled to already classic cardiovascular risk scores. And of course, it can guide clinical investigations in subjects at an already increased cardiovascular risk. And here are all the known determinants of early vascular aging. You can see that hypertension may be the first of these, diabetes mellitus, smoking, obesity, the metabolic syndrome in his general concept, and chronic kidney disease. Of course, there is a multifactorial process. So a patient must get it could increase his age, and of course, in parallel, he might have also diabetes mellitus or hypertension, and all this to act together in order to increase further the early vascular aging. Hypertension is the most well-known cardiovascular risk factor in its own right, but also linked highly with the early vascular aging process, especially values higher than 140 millimeter per mercury are very important in our population. Sex again, but you can see that there is an acceleration of vascular aging in men compared to women, especially under the 50 years old. And of course, all the duration of cardiovascular risk factors may have an impact on early vascular aging. If you have hypertension for 1 year, it is not the same with another patient who may have 50 years and he's not he hasn't addressed well his hypertension. So why is important the vascular aging? Of course, it is important that because it has to do also with cardiovascular morbidity and mortality. As you can see here, every 1 meter per second increase of pulse wave velocity means almost 40% increase of cardiovascular mortality in patients with end-stage renal disease. And this is something very important, of course. Even in total in cardiovascular risk stratification in patients with other health problems, you can see that in model 1, age, gender, and other cardiovascular risk factors such as diabetes, hypertension may predict cardiovascular risk, and the area under the ROC curve is 0.69 for this model. But when we add other tissue biomarkers such as the IMT or pulse pressure, the area under the curve, the ROC curve increases. But when we add in the last model pulse wave velocity index, then we have the best area under the ROC for the prognostic value of cardiovascular risk. And this is statistically different compared to model 3, where pulse wave velocity index is not included. So it is very important in order to understand the cardiovascular risk through early vascular aging. And of course, there is a greater risk for cardiovascular death when we add pulse wave velocity in stroke also. You can see here that both for stroke under or less than 5%, pulse wave velocity is important, can increase the cardiovascular death risk. This is one of the greatest meta-analysis in the field. You can see that includes more than 17,000 patients and evaluates not the early vascular aging, but the aortic pulse wave velocity in order to see if it can improve the cardiovascular event prediction. And the answer is totally yes. When we add pulse wave velocity, we increase the hazard ratio for all this. Hazard ratio for cardiovascular disease is 1.3, 1.30, for stroke 1.28, and for coronary heart disease almost 1.23. So and all these are statistically significant. So even aortic pulse wave velocity is very important for this region. Taking all this into account, Vlachopoulos et al. In collaboration with Artery Society uses carotid and femoral pulse wave velocity, but also brachial ankle pulse wave velocity in order to prevent not only primary but also secondary cardiovascular disease. And you can see here that carotid femoral pulse wave velocity is a level of evidence A, but for brachial ankle we have level of evidence, B. Let's go and analyze what's going on with the guidelines of European Society of Hypertension. The previous guidelines included pulse wave velocity as a very useful index in order to screen for our patients for hypertension-mediated organ damages when we want to screen them more detailed, not in the basic everyday clinical practice. And this is why, this decision was because the routine use of pulse wave velocity measurement is not practical, and that's why it is not recommended for the everyday clinical practice. However, the latest guidelines from European Society of Hypertension changed a little bit in this part. They still recognize carotid femoral pulse wave velocity as the gold standard for measuring large artery stiffness in Europe. And they evaluated it as evaluate pulse wave velocity as it is very useful clinically in hypertensive patients. Evidence from Framingham and European studies shown that the increase of arterial stiffness is highly prevalent in the hypertensive population. And two meta-analyses in the field showed that not only CF pulse wave velocity, the carotid femoral, but also brachial artery, excuse me, have shown, excuse me for this, both pulse wave velocity values have shown the ability to more accurately classify cardiovascular risk compared to conventional risk-based scores. So when they added CF pulse wave velocity in Framingham cardiovascular risk factors, then the net reclassification index increased for 25, almost 30%, which is very important. So taking all this into account, they decided to recommend all doctors to use CF pulse wave velocity as a hypertension-mediated target organ damage, equally this time with the left ventricular hypertrophy, with kidney dysfunction, carotid atherosclerosis, and lower extremity artery disease. And this is very important. This is the novel from guidelines, and this is very important. Now, why they have said that the pulse wave velocity is not very practical? Is it correct or not? Of course, it is. And this is because, first of all, we need this machine. It is expensive. And furthermore, we need a very experienced person, experienced clinician to use this machine. The technique is also very difficult. We should have a quiet examination room, constant temperature at low light. And furthermore, the patient has to refrain from eating food, caffeine, and tobacco for 3 hours before recording, as well as drinking alcohol for 10 hours before recording. Finally, we need to have more measurements. We need almost 3 measurements, 5 minutes after the first measurement, in order to ensure that we are correct with the first one. So, furthermore, besides all these clinical problems, the problem is that the pulse wave velocity by its own doesn't evaluate other determinants of early vascular aging, such as age, sex, BMI, diabetes mellitus, and kidney function. That's why, for the first time, Yan Li et al. Decided to create an index, the Ambulatory Arterial Stiffness Index, in order to evaluate arterial stiffness, taking into account not only the blood pressure from 24-hour recording, which is very important determinant, but also taking account the age of their population. ASI has shown its importance all these years, and has been correlated with cardiovascular mortality, cardiovascular morbidity, such as stroke and coronary heart disease. However, even ASI doesn't take again into account other determinants very important. And what we do in our clinic, we evaluate other parameters such as BMI, diabetes mellitus, in order to see which is important for pulse wave velocity not only, but also for early vascular aging. And in the multivariate analysis, we showed that the age, but also eGFR, diabetes mellitus, and systolic and diastolic blood pressure from the 24-hour recordings are very important to determine and define early vascular aging. Taking into account all this, and also the results from the area under the curves, ROC curve was the better for ambulatory systolic blood pressure, almost 0.6 and statistically significant. We wanted to create a model in order to evaluate early vascular aging from simple determinants that we have in our clinics in everyday clinical practice. We used random forest for this purpose, and we concluded to the early vascular aging ambulatory score. EVAS was evaluated by 24-hour systolic and diastolic blood pressure, 24-hour heart rate, age, sex, BMI, the existence or not of diabetes mellitus in the history of our patients, and also eGFR. And here you can see the importance, the Gini index, the importance of its factor separately. And the total accuracy, sensitivity, and specificity of our model. And you can see that the average was very good for accuracy, 0.8, but also for sensitivity and specificity. After this, we created an application in order to evaluate easily the early vascular aging ambulatory score. And what we have done, we created an application. You can see it, you can find it easily if you Google the World Early Vascular Aging Ambulatory Score, and if you put different parameters of your patients, you can see the probability of this patient to have early vascular aging. Having this on your mind, you can decide if you can send if you want to send your patient in a special clinic to evaluate it further, or if the patient is okay, and you can keep and treat appropriately and based on guidelines. Here is how the application looks like, and here is the external validation of early vascular aging ambulatory score. In order to see if the specificity and sensitivity of our model is fine, we decided to have a retrospective cohort study, included almost 800 patients. 50%, almost 50% were men, and to see if the score is fine in this independent population. The results were fine, more than fine, I can say. Sensitivity was 98%, and the specificity was calculated at around 75%. Also, we had a high positive predictive value at almost 95%, and the negative predictive value slightly lower, but still fine at 92%. So to conclude with the vascular aging ambulatory score, I think it is very useful. You can use it. We have proved that it is extremely, the external validation proved that it is fine to use in order to predict early vascular aging for your population. Of course, it is not only ASI and the early vascular aging score. There are other two scores in the literature. The first one is a SADSE, which uses the clinic systolic blood pressure, and this is the only disadvantage of this score: age, glucose, and TGFR, in order to predict aortic stiffness. And finally, there is also the decision tree model, which is which seems to be very accurate, but it uses very many, determinants. So this is a problem because in the clinical practice, we do not have all these determinants available, such as not only diabetes, but also the existence or not of cardiac plaque, the albuminuria, and the endpoint is again aortic stiffness. To conclude, arterial stiffness is a very important marker evaluating hypertension, target organ damages, and cardiovascular risk. The new scores could be used for cardiovascular risk stratification. They could also add, they could also add their clinical importance when they added in other cardiovascular scores, such as the stroke and Framingham. And finally, in the future, the prediction of early vascular aging could be used to guide early lifestyle or pharmaceutical interventions in order to prevent future cardiovascular events. Thank you very much for your attention, and please don't forget that you are as old as your arteries are, so don't forget to grow younger and be very careful with your health. Thank you very much.